All right. Hello, everyone. Welcome. I see everyone joining in. We'll give everyone just a second before we officially start. Welcome, everyone. Hello. All right. I'm going to go ahead and get us started. We got a lot of good content today. So, welcome, everyone. Today, you're going to be hearing about understanding the importance of EM codes and risk adjustment from Centauri Health Solutions. Before I turn it over to our guest presenter today, I just want to go over a few housekeeping notes. So you will notice that for the duration of the webinar, your cameras and mics are going to be muted and off. This is for your privacy. But if you have any questions throughout the webinar, please feel free to drop those in the Q&A box at the bottom of your screen. Ray's going to do her best to answer those at the end of the webinar, but if there's any she can't get to, not to worry, she'll follow up or the team will follow up with you directly afterwards. I also just want to give a gentle reminder that Rise will send out an email tomorrow with access to the recording as well as today's slide deck. So without further ado, I'm going to turn it over to Ray.
Hi, everyone, and welcome to the presentation today. I'm so glad to have the opportunity to speak with you all. Want to tell you a little bit about myself first and foremost. Again, as Bailey mentioned, my name is Rey Gross, and I'm with Centauri Health Solutions. I'm the coding education manager. So, kind of give you some background perspective on me and why we're going to be talking about E&M coding. I have been a coder since 2003. I actually, previous to that, started off working in medical billing. I started off signing claim forms and worked my way up. I've obtained my certification from APC in 2003. And I spent the majority of my time working in prospective coding. So I did a lot of work with different providers, worked in many different types of specialties, such as cardiology, geriatrics, many different specialties. I really enjoyed the coding aspect of what I was doing. But then I really also loved the side of doing medical billing. So I owned and operated a medical billing company for several years, but my heart and soul was always with coding. And so I made the transition from medical billing into doing full-time coding work. I did a lot of audits for different types of providers. Some of the auditing I did was in conjunction with CMS. I would do provider audits, E&M coding specifically. And then I decided to tap a little bit into the educational side of things. And that's where I really found my passion, was with teaching in brick and mortar schools, and really fell in love with the education side of things. So I spent the majority of my history has been in Profi. I entered the risk adjusting side of things in 2015, and that's where I've landed now and have spent most of my time there. But what I really found interesting was a few years ago, really became heavily involved in Medicaid. And Medicaid is a different side of risk adjusting where you're having to look more into the full complexity of the chart. So initially, I did a lot of work in Medicare, and then I did work in commercial. And so you were really honing in on those mapping codes. Medicaid opened up a different world because I really now had to tap back into my evaluation and management so that I could understand the complexity of Medicaid coding. So where you may hear that terminology of complete code capture. So that's what really led me to want to do this presentation on E&M coding, because we really don't think so much about it. But in order to do Medicaid coding, you really have to understand a lot about what is involved in those evaluation and management codes to really make sure that you're capturing appropriately for Medicaid. And it's also very relevant when it comes to coding for the MA side as well as for the commercial side as well. So in this presentation, I'm going to do just a brief overview of retrospective coding. Of course, most of you on this call pretty much are familiar with risk adjusting. So it's going to be a very, very high level overview of just what risk adjusting is. I know some of you come from different areas. You may be working with a health plan. You could be a retrospective coder. Maybe you're in the CDI sector. So there's a lot of different backgrounds here from here that are with us. So I want to make sure I'm touching on everything as much as I can. Then we'll do that brief overview of evaluation and management codes. Some of you, may have only ever worked in risk, so really may not have a full perspective of E&M coding, or if, like me, it's been a long time since you've worked in that area. So we're going to talk about some of those changes. And then also, what's really the bulk of this presentation is really why it's important to understand E&M coding and how it works in conjunction with risk adjustment in general. And then also ways that you can work with your staff in getting them up to speed on E&M coding. So maybe for some of those that have never really been exposed to E&M coding, or were only exposed for those that are certified, that are CPCs or other types of coders, and then how to get them up to speed and the resources that you can use. So we'll talk through a lot of those. So let's first of all talk about that snapshot of risk adjusting. Again, this is just a really high level overview. So when we think about risk adjusting, we're thinking about the management of those patients' chronic conditions. So ideally, the providers should be working through those patient chronic conditions, ideally at least one time per year, depending on the type of chronic condition you're talking about. Say it's a diabetes patient, you may find that those patients are being managed, at least every 3 months. Whereas a condition where a patient has pulmonary hypertension, that may be something that's managed at least once a year through maybe having an echo done, something to that effect. But basically, you're managing those chronic conditions the patient has and assessing conditions that may be new to the patient. For example, a patient may have diabetes that has become uncontrolled. And so now that's progressed in CKD, or it's progressed into, peripheral vascular disease, neuropathy, things like that. So there are things that may occur throughout the lifetime of that patient. Then also we're thinking about the different types of populations that the patients fall into. So that could be from your younger population all the way up to your older generation. So historically, we have the three models that we're talking about. So you have your MA model, which is your Medicare. That's going to be your older population. So you are going to see a different subset of codes associated with those. So we talk about those mapping conditions. So you're going to have that subset of mapping conditions for the Medicare population. We also have the commercial population. So the commercial population is going to be that mid-range, I would say, thinking about your pregnancy codes, which are a little bit new in that area. So you have your commercial, that mid-range category. Again, where your older population, you're maybe going to deal with a lot of the diabetes, and some of those conditions are most prevalent in the older population. Some of those transition also into that commercial environment. So diabetes is something we're seeing in the younger generation as well. And then you have your Medicaid population. So this would be what I would say is probably more untapped than the other two populations. So you have the Medicaid model, which we generally think about as being complete code capture. Now you're looking at signs and symptoms. You're looking at unconfirmed diagnoses. You're looking at just a larger subset, but now also thinking about the children that are being involved in that population. Medicaid, as we know, or maybe you don't know, is state specific. So a lot of times when we're coding, we're doing complete code capture because things are going to vary according to the states. Usually from our perspective, we don't worry about the different states. We're doing complete code capture so that when those codes are submitted, the states know what is going to map for their specific state. So if you're in Texas, you may have the different subsets than maybe if you're in California. So the Medicaid population, again, is usually based around children, pregnant women, and it could be anybody. So again, because the different states have who is eligible for their states, you're looking at a larger subset of diagnoses codes that you're going to capture. The other thing to consider when it comes to risk adjusting is what area you are working in. Some may be working on that prospective side where they're working with providers for codes are being captured before submission. And then you also have that retrospective side where you may be looking at documentation from a previous year. In my situation, I work on the retrospective side of things. So we are looking at charts that could be, a year old, year and a half old. So we're looking at things from the retrospective. So we don't have the ability to go back and query. So that's going to be that difference between prospective and retrospective. So prospective being that you have the ability to go back and query, you have the ability to talk to providers for better clarification. That retrospective side, we're looking at what's documented at that time. So I want to take a quick poll really quick here to find out, what population are you serving in? So you're going to notice I have the Medicare population, and no matter whether you're working in prospective or retrospective, do you primarily deal with commercial? Do you work with the Medicaid side? Do you do a combination of these? Do you maybe do all, or maybe you're uncertain? And uncertain may sound like, well, why would I not know that? There are some companies that you work for, especially if you're working on the retrospective side, you may not be told who your client is. You may not be told, you're just told to code based on, a capture of sorts, and you really don't know where that data is being submitted. So just kind of curious, where do you fall? I'd like to know that. So it looks like from the polling that there's a large number that are in that Medicare environment. We really don't have any that aren't certain. We have the combination and then all. So that is really great to know because, you know, depending on where you are, depends on what your viewpoint may be of some of this. I'm really, and as you noticed on here, Medicaid is not always that biggest subset, but Medicare is heavily where we see most of our coding done. I think that's where a lot of people tend to fall because that's what we've typically done in the past. But Medicaid is really becoming more prevalent, and the documentation is also being driven by E&M coding as well. So that's why I think it's going to be important for us to have this conversation, about how E&M works with what we do. So first and foremost, what is evaluation and management? So as I mentioned, I work with coders that have only ever worked in risk adjusting. Years ago, in order for you to have obtained a CRC, which is the Certified Risk Adjusting Specialist certification, it was a secondary credential through AAPC if you were a CRC. In recent times, the CRC is now a core credential. So what that means is there are some coders that really want to go into risk adjusting, and so they have their CRC and really have never been exposed to E&M coding. So that's why I want to talk a little bit about, what is evaluation and management. So E&M is why was the patient seen? So all of you have I'm sure at some point have gone to the doctor. So you go in and present, and you're presenting for you're being seen for your cold. Okay, so in your E&M codes, there's a subset of 5 characters that are saying why was the patient seen? Was it for a new patient visit? Is it for an established patient office visit? Are you presenting for a consultation, whether that be inpatient or outpatient? So there's all these different types of codes it's describing why was the patient being seen today. And that information is carried over on claims, your CMS 1500 claim form, for example, that is submitted to insurance companies so they know why the patient is being seen for that day. Again, was it a consultation? Was it an office visit for a new or established patient? Was it for a nursing home visit? So it's very important. And let's talk just briefly about, I'll use established patient visits. Those codes can range anywhere from a 99212, which is a low level office visit, and go all the way up to a 99215. Again, that is for an established patient evaluation and management service for a patient. And what you're basically telling the insurance company when those are submitted is that if you have a 99213, it was a pretty easy exam. It's an established patient and it's for a low level. Now, if there's a little more complexity that's being involved, you may have a 99215, which is going to say that that provider spent a lot of time dealing with the patient. There was maybe a lot of conditions that were being managed. Maybe there's something that's being new conditions, whatever the case may be. There's a lot of workup that's being involved. So you're basically talking to the insurance company through the usage of the codes. All of this information is being reviewed from the documentation. So as you're looking at records, you may see that they're explaining that the patient is new to that provider. Okay, that's going to indicate to your coder that it's a new patient visit, or it may say the patient returns for a follow-up. That's the indication that it's a new patient visit. Now, I do want to talk a little bit, just really briefly, about when we talk about new versus established. From documentation purposes, when you're reviewing records, you may see sometimes there's a mention of new to this provider, but not new to the office. So when we think about new patients, we have to be really careful. A new patient is someone that has not been seen by a specific group within the past 3 years. So if you have Dr. A and Dr. B, and they're in the same group, if they see Dr. A today, and a month from now they see Dr. B, that's still an established patient. So a lot of what you see on the documentation is really relevant from a coding perspective. Now, maybe for us as risk adjusting coders, it doesn't matter that much, but just want to give that background and history. So it's the way that also E&M codes are about the way that the providers and organizations are paid. Again, these claims land themselves on a CMS 1500 claim form. If you're my older generation, we used to call them HCFAs, but currently the CMS 1500 claim form. And so when you're billing on those, that determines the pay. So a 99212 is a lot different than the payment of a 99215. So it's the amount of money that's coming in for these providers. And I stated organizations because, as I mentioned, you also have group practices and they have their NPI numbers and so forth. And so the way that those are billed determines that payment amount for the providers, for a single practice, and for those organizations. So what all is included when we think about E&M codes? We've already talked about this, but the office visits for both those new and established patients. We also think about E&M codes when it comes to our hospital, inpatient, as well as observation services. So most of us have at some point in our careers have seen inpatient charts, right? And so we see the progress notes, we see the consultation. So when you think about those inpatient visits, when we code, we're looking at a lot of times, is there a discharge summary that's present? So our approach for coding those may be different, but on the pro fee side of things, those are being billed up front. They're looking at, is it an inpatient consultation? Is it an observation? Those things matter from an E&M perspective, okay? We also have our emergency department visits, our ED visits. So for those follow E&M codes. They also have different ranges that are coded based upon the complexity as well. Same thing that we talked about for our 99213s and so forth for our office visits, but there's still that level as well for the ED visits as well. We do code from those a lot of times, and we look at those. Those are relevant for risk adjusting because a lot of times we're looking to see, did that ED visit result in an admission? Okay, so that affects our coding, but we do look at those. We look to see whether we're coding them, whether we're, if we're going to code them, we're following outpatient guidelines and so forth. We also have those E&M codes. There are a subset for our nursing facility services as well. So I think about where we look at SNF visits and things, our skilled nursing facilities. And then we also have home visits, which has their category as well. Okay. So those are the different areas when we think about E&M. And I'm going to talk a little bit about some other areas as we go through this, but that's our general subset. If you go to your CPT book, which we're going to talk about in a second here, but these are the different categories that fall under the evaluation and management service, or as I call it, E&M going forward. So a little bit more on evaluation and management. So there are two places that I want to talk about. First is the CPT code, which is your current procedural terminology. And those are created and maintained by the AMA. So if you have a CPT book in hand, or if you're looking at anything that's CPT related, you'll notice it's always going to have the AMA. They own that. When we think about our I-10 books, you have a lot of different publishers of I-10. But CPT is always going to be created and maintained by the American Medical Association. So they're the ones that maintain that book. So when it comes to E&M codes, I did want to put the range on here that I wanted to talk about. So you have 98000 through 98016, which may throw some of you if you haven't been around with E&M for a while. And I'll go back to that in just a moment. And then you also have the more familiar 99202 through 99499. So all of your E&M codes for, I'm just going to call it for now, our Medicare, well, for all of our subsets are going to use that range of codes for E&M. So for your office visits and so forth. Also bundled within that range of the 99202 through the 99499, you also have your wellness and preventative care services. And we're going to talk more about that in just a moment here. Now, what may look a little different to some of you if you have not spent any time dealing with E&M codes, the range of the 98000 through 98016 is dedicated to those, as we're starting to see more and more often, the telehealth visit. So there are distinctions between when we say telehealth, when there's video enabled or when there's audio only. So in 2025, there was some different subsets that were added for codes to further identify how those telehealth services were being performed. So they added this range of codes in. So that's why you're going to see that little range that may be a little unfamiliar to you. So those are surrounding, again, those telehealth visits, which are really important to us as risk adjusting coders because we're looking to see, is it audio where you need the audio and or video? So for Medicare, we're looking for that video and audio component. For the Medicaid populations generally, you're able to code from audio only. So just wanted to mention that. I also don't want you all to forget about the HCPCS book, which is the level 2. So it's that secondary component of the CPT book. So what I wanted to call out here is for the Medicare population, when it comes to their wellness visits and their welcome to Medicare, and we'll talk more about that in just a few moments, that I consider it or like to talk about it is the equivalent of the CPT codes for your preventative care for Medicare patients. Okay, so when you are commercial and you have maybe Aetna or Blue Cross as your insurance, anything that's non-Medicare, you're going to use the CPT to identify your wellness exams for insurance purposes for submission. If you are a Medicare patient and it's for an annual wellness exam or your welcome to Medicare, as they call it as well, you're going to use your HCPCS book, and it's going to either be your G0402, which is your welcome to Medicare, which is a one-time only services performed, or you're going to use the G0438 or G0439, which is for the 38 is for the initial annual exam, and your 39 is going to be your subsequent visits every year. So Medicare likes to have every single year they want their patients to come in for a wellness exam. So they're real big on that, and it's something that you're talking to the patients about. How you're kind of doing a run through of, have you had any falls? Do you have smoke detectors, things like that. So the other thing, so let's get more into now, more about why E&M codes matter in risk adjusting. So first and foremost, I would like to think that it's about identifying that you have a valid face-to-face encounter. That is something that we are really, really looking at in terms of when we do risk adjusting in general. Do we have a valid face-to-face encounter? Okay. So for looking at codes, there are many times we have which appears to be an actual visit. Sometimes you have sign off by a provider, but you realize that service is being provided by a non-valid provider type, such as a nurse visit. And so for a nurse visit, maybe there's an injection that's being given. They would bill out the 99211, which is for a nurse visit. So reviewing documentation is really key to make sure that you have a valid face-to-face encounter, and that service that's being provided is being done by a valid provider type. Okay, so that's one thing that is really helpful. Also, formats can vary. I know most of you are from various organizations. Some some organizations I see have a very clean, what we call SOAP note. It's very clear. Everything is blocked off in a great form. Sometimes I've seen formats where maybe all of your past medical history and so forth is on the left-hand side of your screen, and you have all your relevant information going down the right side of the page. There's sometimes where you have your assessment and plan at the top and your HPIs at the bottom. So being able to identify that you have a valid face-to-face encounter and being able to navigate through your documentation is going to be key. And also looking at key terms that we just talked about. Is it a follow-up visit? Is it something that's being initiated by a nurse? So your formats are really important to make sure that you're looking at a valid face-to-face encounter. And if you can identify terminology that would be used from the E&M side of things, it may help you to better identify, how would this be billed out? Would this be billed out on a 99210? Would this be billed out by something that's non-risk adjusting? So maybe you take a pause on that. It's probably a little odd that I threw in here psych visits. I mentioned psych visits because I think a lot of times when we think about risk adjusting, we're so focused on looking at a full PE, for example. Especially, we have some of our coders that are a little bit new, some that have a little less experience. And so we're taught historically to look for that PE. When you look at some of the site visits, even though it's not identified as telehealth, there may be some areas that are missing. So being able to understand how this visit may have been billed out on the pro fee side of things would help you to better understand whether you have that valid face-to-face encounter. So recognizing how this would have been billed in the first place may be very helpful to you. So site visits are some of those that sometimes can be a little difficult to navigate because you're not seeing some of the elements that you're used to seeing on maybe a sick visit. So those site visits are one, sometimes they're tricky and they're often overlooked. So wanted to kind of point that out. You may be seeing the interaction between the provider and the patient, but not just a regular, a clean form of an encounter. Also, when it comes to E&M codes and risk adjusting, making sure that you know what you're looking at. We're going to talk a little bit more again in depth about wellness visits and so forth. But if you know what type of visit you're looking at and what type of visit is being performed, it will help you to select the correct diagnosis codes. And we're going to spend a little time talking about this from the Medicaid perspective, along with the wellness and preventative care services. But I wanted to make sure that you understand that knowing the type of visit, which will be billed out from an E&M perspective, will help you to select the right codes. And then again, just kind of following up to what I said, to identify if the service would be eligible for risk adjusting. And we're going to kind of hone in on those in just a little bit here as well. So let's talk a little bit about time-based codes. For those of you that are familiar with E&M coding, maybe it's currently, maybe it's in a former life, historically, we didn't focus heavily on time. So time-based services are now a little more prevalent when we think about E&M coding. So it's changed a little bit how the documentation may look. So time-based services are now considered. So you may not see as much bulk in meat in the notes as you maybe previously have. So that time-based coding can include time that's spent with non-valid provider types. You may see providers document now that they were talking to family members. And I know in some of my recent documentation, as we're getting into 2025, a lot of times in the assessment and plan, I'm starting to see more now where they're saying 25, minutes was spent talking to other providers and reviewing documentation, and 15 minutes was spent in face-to-face time with the patient. So they're separating that out a little bit. Now, for our purposes of risk adjusting, that doesn't matter as much. But from the E&M side of things, their leveling may change a little bit. So that difference between a 99213 versus a 99214. So 99213 is kind of that mid-level visit. A 99214 is just a little bit higher level visit. But I've noticed that the documentation looks a little bit different because you're not seeing so much bulk within the body of the note. And when I say body of the note, the active portions of the record, meaning the HPI, the history of present illness, when I'm thinking about the PE or all these, the review of systems, you may not see so much brought into the active portions of that part of the note, but there's a lot of information that's contained within the assessment and plan. So wanted to kind of bring that out, why you may be seeing that in your documentation more, whether providers are specifically calling out the time spent on non-face-to-face time with the patient, and they're calling out the conversations they're having with family members or other providers and why that's relevant now. Also, what's helpful when it comes to E&M coding is determining what provider actually rendered the services. So the first part I want to talk about is split or shared visits, and some of you may not dive too much into that either. Again, this is something that's more relevant when you're talking about coding from a pro fee side of coding. So when it comes to split and shared visits, I just want to touch on this, that when you're looking at it from a pro fee side of things, which provider performed the substantial part of the services. Okay. So that would have that factor involving, determining which provider really rendered that service, for example. And that would be when you're thinking about when time is, not being considered. You also have which provider performed the service when, the majority of that time was being sent by a certain provider. So who performed the E&M, who performed a major part of the service may determine who is rendering that service. So those are some things that you may want to look at. Is it a resident? Things of that nature. Sometimes we have sign off by both providers. You may have a resident and you may have or you may have a nurse practitioner and an MD, and they both signed a note. They may both sign the note, but going back trying to look at the record to see which provider rendered that service. So there's sometimes some confusion on, okay, I have two signatures, who is it? Or you may see two MDs sign a note because one is a resident and one is the MD. So sometimes it takes a little bit of deep diving. From a retrospective side of coding, sometimes that can be a little difficult for us because we can't query all the time. So we rely on the documentation being, very clear to us. So I think that's where our coders on the prospective side, or those that are actually, on the pro fee side of things that are helping to better, put better information on the encounters. So when they come to my side of the arena, it's clear for me. I do want to talk briefly about student notes from a retrospective side of things. We historically don't code from student notes. However, I did want to mention that there are certain times where you may see the student designation, and some of you may have seen a PGY1 or a PGY2 documented. So the PGY is for postgraduate year, and those are residents, and those are generally eligible for capture. Now, I do want to, mention that you should follow any guidance set in place by your own organization. This is just kind of general information that I'm presenting, but make sure you're following the guidance, of your specific organization, whether they allow for these or not. But generally, if you see the PGY, and sometimes it may say student because they are post-year graduates, but the one for the designation 1 year postgraduate, two being 2 year postgraduate. But when it comes to an actual student, those are not MDs, and we generally do not code from those. However, you may see that there's information contained within that note that the provider, their teaching provider, has performed or reperformed the major parts of the record, so the PE, and also has done that medical decision making. So sometimes they're contained within one note, and sometimes they are a complete separate note. But just look at your documentation carefully to make sure that you're selecting and coding when appropriately. So other reasons that E&M codes matter in risk adjusting is by identifying the correct population. So earlier I talked about Medicare, Medicaid, and commercial. So let's talk about the Medicare population a little bit further. So I did mention earlier about that initial preventative physical exam component. So when it comes to that welcome to Medicare, that would be billed out using that G code that I talked about from the HCPCS coding. But there are times where a patient may not really fully understand the complexity of that visit and may introduce their sick visits. Some providers will ask them to reschedule. Sometimes there may be a combination of these visits happening concurrently. So you just have to look at the documentation to determine what happened. You may, and many times the provider will actually do two separate notes. So you'll see their initial physical exam component on one, which is a special document because there are certain things that have to be followed in that that initial preventative care exam. Then you will see a separate note by the same provider on the same date of service with the sick component. Those can be billed out separately. But the Welcome to Medicare exam, it looks a little bit different because you're not going to see what you would see normally in a sick visit, but those are codable. If there's something on there that you are able to capture from based on coding from the MA environment. Separately, we also have the annual wellness exam. So as I mentioned earlier, you have the initial, which happens the very first time, and then you have your subsequent. So there's also certain key points that must be included in the annual wellness exam. So there are certain things that the provider must address. Again, you may also see that wellness exam occur on the same time as a sick exam. So the patient is coming in and they have their, their wellness exam scheduled. Wellness thinking about, has a patient had any falls? Do they have smoke detectors? Are there guns in the home? Things like that. But then the patient starts to get over into wanting to talk about some problems they have, which is not really a component of their wellness exam. So the providers generally are not going to turn around and turn that patient away. Okay. They're not going to do that. Instead, they will usually do two separate notes, and then those can be billed out with the use of a modifier. And I'll talk briefly about modifiers in just a little bit. But you do have the ability to have two of those visits, and they may look very different depending on the coding software you have, sometimes it may merge into one because you have one data service by the same provider. Um, but they are two completely different visits. But wanted to mention that because you may be wondering, why am I seeing two separate notes? And that's why they cannot be billed generally on the same note. You're going to have your wellness exam here and your sick visit here. And again, a lot of providers don't want to send you away and make you come back in separately. Now, I do want to mention that there may be, from a billing perspective, there may be a separate copay because they are two visits that are occurring at the same time. So let's talk about the Medicaid population just a little bit. That's going to look a lot different. They also do have a series of wellness exams. During those exams, there are going to be age appropriate counseling that's going to be included. It may be for diet, exercise, contraception, and so forth. When I mention age appropriate, the conversation you may have with an 8-year-old may be different than the conversation you have with the 16-year-old. So let's talk about the 8-year-old, for example. The provider's going to talk to him, don't eat candy for dinner. You need to eat your fruits and vegetables. And they may term it as counseling. As I mentioned, Medicaid is at the state level. So different states have different things that are on their checklist that they must touch on. So when you're talking to a Medicaid patient, you need to talk about, 8-year-old eating your fruits and vegetables. You need to talk to them about doing exercise, go ride your bike, things like that. Let's jump to the 16-year-old. Those conversations may be a little different. They may be talking about, contraceptive STDs. It's a horrible thing to think about, but at that age group, there are different conversations that are being had. And when you look at the assessment and plan, the providers, for documentation purposes for Medicaid, they must touch on those items. So they will be separately listed out as the assessment and plan. So the reason why I'm mentioning this is because you have to understand what is included in an evaluation management service for a wellness exam to understand from a risk side, if you're doing complete code capture, what is appropriate to capture and what is not appropriate. So generally, if you look at all of what is included in the subset of a wellness exam, those counseling codes, unless it's something that's over and beyond and there's some other criteria, they do not need to be coded separately because they're inherent to the wellness exam. Okay, so that's why it's really important to understand what is included in the subset of a wellness exam to understand what can be coded in a complete code capture if you're doing Medicaid coding, because you don't need to separately capture all of the dietary counseling codes and all of these things. It's understood that those things are going to occur during that wellness exam. The population's going to, again, the age variance is going to change. You're going to talk a little bit more about, contraceptive, to a 16-year-old that you would never talk to when it comes to an 8-year-old. An 8-year-old, you may talk to them more about riding a bike and different types of exercise and go play on the playground, which you would never talk to a 16-year-old. Then as you get a little bit older, those are going to be different conversations that you would have with a 40-year-old. Remember, the Medicare population is generally, there's some exceptions, but generally you're going to be looking at the 65 and older population. They have their different types of exams going back to that annual wellness exam. Someone under the age of 65 is probably likely going to be on a commercial plan. So those conversations are going to be had a little bit different. Okay. So keep those things in mind. The other things that you want to identify when you're looking at the Medicaid population are your immunizations. Okay. Those are things that you really want to pay special attention to. Was the immunization actually performed at that visit, or was it recommended and declined? Those things. So thinking about it from an E&M perspective, what would you be coding out? Although an E&M immunization is not, I would say it's not per se an E&M code, but it would be done in conjunction with an E&M wellness visit usually. Same process happens. We talked about when it comes to E&M codes that you have with the wellness exams for the Medicare population and for the commercial population is there can also be that 2 visits in one that takes place. Okay. So for the Medicaid population, you have the 2 visits in one where there could be the wellness exam and a separate sick exam that happens at the same time, can be billed out separate. Now, if immunizations are being performed, there are times where a provider, and I've seen it happen, they may decline the wellness visit if they're doing a sick visit, if it converts to that. So really important to look at documentation to see if something was stopped and was not carried out. Okay. So other things that we need to consider is going to be, and this is thinking about our risk side of things and what will be billed out. I called in dialysis visits because generally dialysis service we don't code those from a risk adjusting perspective. Sometimes the providers do their rounds during their dialysis visits. Many times those are not codable by us. So just kind of want to further explain that while there is a visit taking place, it's done during the dialysis rounds, we normally don't code from those. Looking at documentation too, because a lot of times we'll see a myocardial infarction to only find out that it's a follow-up to that visit. Now, if you're within that, window of time where you can code it as current, that's fine. But if you're outside that window, a lot of times that'll be brought in. So what kind of visit are you looking at? Are you looking at an inpatient stay and it's on an inpatient consult or a progress note where it's appropriate? Other types of E&M codes that we don't think so much about are those pre-anesthesia visits from a prospective side of coding. Those would be billed out as as an E&M code, and we should be appropriately capturing from those pre-anesthesia notes. I think some people see anesthesia and they pause, but we should not ignore those. And then radiology, is it invasive or non-invasive? Generally, radiology, we generally from a risk side don't code from, but there are times that they are appropriate. So looking at the documentation carefully and thinking, how would this be billed out? I look at that sometimes. I'll kind of do that quick dive. Would I be billing this as something that only a provider would be able to do? Or is it something that would be something that a non-valid provider type can perform? And documentation always drives these things. So let's talk about understanding the impact. So I said I was going to talk about modifiers a little bit. So, we think about the modifier 25, which is used when 2 things can occur at the same time. Thinking about to those wellness exams. There are times where 2 services can be provided at the same time that otherwise would not be. Again, your documentation has to support these things. So looking at modifiers can determine you be coding something separate, going back to those wellness exams. 2 visits occurred at the same time. There are a slew of modifiers that we use that are attached to E&M. So modifier 24, modifier 25, things like that. So those are things that I'm not going to dive too far into, but if you're familiar with any type of E&M coding, think about what modifier would I use? Would that be appropriate? Things that we do think about that we do from risk side that we don't think about from a pro fee side of things are the medical decision making. We've all heard the term, meet, tamper, or some of you may use support. We use support often as something supported. So when it comes to E&M guidelines, what falls into those categories of things that are being looked at are medication management, referrals to other providers, the management of chronic conditions, reviewing of outside records, as well as that social determinants of health. Okay. I think what's important about this, all this information, if you go look at the CPT guidelines, this information is all contained within the E&M section. And that carries over to us for risk, because aren't these things that we generally look at, especially if you're looking at the Medicaid population, you're looking at those SDOH codes. But all these things that are contained within the E&M section are things that we look at from a risk adjusting side. So I think it's really powerful to look at that combination together, that what we do really translates into E&M as well. So there is that cross. So my next poll here, I'm just curious, how many of you have ever really thought about the impact between E&M and risk adjusting? I'm just curious if you ever even really thought about it. I think for me, I most thought about it when our organization started working heavily with Medicaid coding. We started doing it a couple of years ago, and it really made me kind of pull back into my brain. Wow, I didn't think about how much E&M really had an impact with risk adjusting. I guess because I started looking at the preventative care services more. I started looking at the wellness visits, looking at, I wonder if I was working on this side, how would it impact me? How would I build this? While I don't do it, it really helped me put things into perspective a lot from that Medicaid population. So I'm curious to see the results, to see if you've ever really thought about it. And this is not a poll question, but just in the conversation we've had, do you think that it may have changed your perspective a little bit? Wow, I hadn't thought about that. Or I worked in Profi years ago, and I worked in the E&M side a long time ago. And now that I'm thinking about it, I did not realize that the connection that it had. So good. I'm looking at 72% of you really considered it and 37 not so much. And that's not really a bad, that's not even bad that you had, for those of you that said no. I think it's something that we really don't think too much about, but hopefully during the course of the conversation we're having today, that you may see that it is something you maybe should kind of think about. And I'm not asking, anyone to do a deep dive into it. But let's talk a little bit more. Just what I was saying. Okay, I work in risk adjusting. Why do I care? All I look at is I-10 codes. Yeah, and I think that's kind of neat, because I remember when I entered risk and learned how to do it, was told, oh, you're just looking at I-10 codes. I thought, oh, okay, and maybe thought, oh, that's easy, I can do that, and realized how much more complex it was. But really thinking about it, and I'm going to talk to some of you that maybe have really that are CRCs, okay? That if you are a CPC or certified, CCSP with a HEMA, any of those areas, remember when it comes to pro-fee coding and coding on a claim form, every CPT has to have an I-10 code. They work in tandem. You can't have one without the other. You've got what happened. It was an E&M visit. It was radiology. It was pathology, whatever the case may be, was a surgery. Every CPT code must have an I-10 code that goes together with it. They work in tandem. So as we are doing things in risk, we have to make that correlation when it comes to thinking about the coding we do with risk adjusting. And so if you have that understanding, the why helps with the what. What happened? Why did you do it? And what happened? And we are heavily involved in that what, because we're focusing so heavily on managing the patient's chronic conditions. And that's huge. We play a huge part in healthcare in general. So while we are focused on the I-10, I think it's good to have that background of the CPT that we sometimes forget about. And that also gives that better overall outcome. So it goes back to what risk adjusting is about, is managing the patient's chronic conditions and helping those patients receive the great care they're receiving, and to help them manage those conditions so they have better health outcomes. So what can you do as an organization? So the one thing I think is work with staff that has only ever worked in risk. That could be two things. They're a CRC that never really focused much on E&M, or they never really worked in anything other than risk adjusting. So myself, I've spent the majority of my career in non-risk, and I think I'm kind of getting to that midway point where it's almost about even. Um, but there are some individuals that pass their coding exam and they did the test, but never ever worked in E&M or any type of CPT. They just thought, oh, I don't want to deal with that. And they walked away from it and now have focused so heavily. But work with staff. Most organizations have someone that's well versed in that area. And you could really help yourself by just having those conversations with them. I always think it's great to know the background behind something so that you can improve on what you're currently doing. Do refresher courses if necessary. There a lot of little mini courses you can do, whether you're with APC or HEMA, because both of those organizations are so heavily focused on all types of coding outside of, risk adjusting coding. Do a little mini refresher course. If you're using some type of an encoder, whether that be Encoder Pro, Find a Code, but any of those, many of them have CPT embedded, so look at those. Um, Also, utilize your existing resource and that you have in place to help them leverage that information and look for mini courses that are free. Such a great, process and such a great resource. I just think that everything that you can do for your organization, reach out to others that maybe are in Profi that heavily work in it, have them work with your staff or work with you to better educate yourself so that we can have these better outcomes in risk adjusting. So these are some resources that I have for you all. We use Find a Code internally. CMS is such a great resource where I found a lot of my information and really helped me kind of hone in a little bit. And then, of course, the American Medical Association, since they are the ones that are the creators and housers and owners of our CPT codes in general. So great resources. I'm here if you have any questions and would like to ask me anything. I loved diving back into my former life to a degree. So thank you so much. And I'm going to pass it over to Bailey.
Yes, thank you, Ray. And thank you so much to everyone for attending. And we just want to thank Centauri for putting on a great webinar presentation today. You will be receiving a copy of today's recording as well as the slide deck tomorrow from Rise as well. So please be on the lookout for that. Ray, I think there were a couple questions. Did you want to see if we could answer any of those?
Okay, let's see here. So let me go
I know
back
there's
in
quite a
here.
few that came through.
Yeah, let's see. So there was a question. So I think one was a statement about Medicare not accepting new codes for telehealth released last year. Yes. And so I did want to mention that some of my information, of course, is based on retrospective. So we always should want to make sure we're doing what's current at that time. We're still doing some back coding. So make sure you're using your resources. So thank you for mentioning that, Donna. And so let's see here about the G221 and the 99214 with the visit. So I believe that there are recommendations that you are able to use modifiers when appropriate, but also make sure you're looking at different carrier guidelines. And keep in mind that Medicare has policies for modifiers that you can use that aren't always accepted by commercial. So depending on what plans, Medicare is generally primary, but not always. So sorry if that didn't really answer your question as well. CEUs, I'm not sure this was answered, but I don't believe there's CEUs for this presentation for a HEMA or APC. Next question, an outpatient prospective diagnosis coding review, post-visit pre-claim. Would love to know my experience and or others. Do you have coders that are CRC and E&M viewing concurrently? Or do you have two separate teams who code what first in E&M versus visit diagnoses? In our organization, I'll just speak from my perspective, we are only on the retrospective side and we do not deal with E&M. I have heard some organizations that do both, but they have those teams a little bit separate. And then I'm sure that there's some that are doing concurrent, but That would be a great question. I'd love to hear the answers to that from some of you as well. Next one, how do you motivate providers to sign proper E&M codes when the codes are placed by the EMR and is usually undercoded? Um, while I don't do that, I will say in a former life, the documentation is going to drive everything, and having those open conversations. We have to be careful on leading, but the documentation drives everything, no matter what that, system has generated, and go back and have the conversation with the providers. So I hope all of you, gain something from this. I've had such a great time. Again, like I said, I've been working in risk, but I always love talking about E&M and love modifiers. So thank you so much for your time. I know we're about out, but I wanted to, just say that, again, we're all in this together. And I'd love to communicate with some of you if you have any follow-up questions and think of something, feel free to send them my way. I'll do my best to try to answer. But thank you, and I hope you enjoyed this.
Thank you so much, Ray. And everyone, just a reminder, you will receive a post-webinar experience survey on your screen shortly after you log out. So please just take a few moments to answer those 3 questions. And thank you all again for attending, and we look forward to seeing you in the next one. Happy
Bye.
holidays,
Thanks, everyone.
everyone.